I'd like to introduce the next keynote speaker, Dr. Otis Brawley. Otis is the Chief Medical Officer and Executive Vice President of the American Cancer Society. He's a professor at Emory University. He's a medical consultant to the CNN network. He's filled positions at the National Cancer Institute and many other places. He's served on many advisory committees, including those of the Centers for Disease Control and the Food and Drug Administration. His book, How We Do Harm, came out last year. Many of you will know it, to much acclaim, featured in the New York Times, Wall Street Journal, and elsewhere, and has generated great debate and interest. Last night, I asked Otis how he'd like to be introduced, and within a moment, he said, he's the Dennis Rodman of oncology. Now, I'm embarrassed to say that I didn't know who Dennis Rodman was, because I come from another planet, but I understand he plays basketball and travels internationally. And after doing a little more research, I'm not sure he's the best comparison, but certainly Otis does share some of Dennis Rodman's characteristics. He's cool and unpredictable. Here he is.
Thank you. Thank you. When I said that, I was actually thinking I live on the fringe. But in any event, it's wonderful to be here. Thank you. This is an international audience, and I am a medical oncologist, so I'm going to use a lot of cancer examples as I talk. But I'm going to tell you right now that the basic theme of my talk is that we need to have some wisdom and some courage to speak up. We need to get out in front and explain to people what the problems are. A lot of folks have been duped. A lot of folks have had fear induced into them. I'm going to talk a little about the economy in the United States, especially the medical economy. I'm going to talk about the tendency of people to want to adopt things early, especially things that are new because they must be better. People generally support science, but they don't really respect science. They really don't appreciate science, and they don't appreciate the process. I'm going to talk about overdiagnosis in cancer and how really an underappreciation of how science has progressed and evolved over time has led to that. And again, I'm going to end with a call for education. Again, my disclosures, including my book. Overdiagnosis, I was asked to define it. In my mind, overdiagnosis is disease which is not really disease. It's something that looks like disease, but it's not disease. There's huge overtreatment, unnecessary care being given, and that leads to unnecessary suffering, mental and physical and financial. Now, let's talk about the cost of health care. This is a very U.S.-specific part of the talk. However, people in Europe and Australia and elsewhere tend to follow the United States, so this may be where you're going if we don't stop it. I was educated as a Catholic, and I went to Catholic schools and was very influenced by several Jesuits in high school. One of them, Father Polakowski, used to always say, remember what it is you know, what you don't know, and what it is you believe. And when I went off to medical school, he said, remember, doctors have a tendency to confuse what they believe with what they know, and I've found that to be incredibly, incredibly true. In the United States in 2010, we spent $2.6 trillion on health care. $2.6 trillion. We spent $1.1 trillion on food when we spent $2.6 trillion on health care. 18 cents out of every dollar was spent on health care in the United States in 2010. That's our gross, 18% of our gross domestic product was health care. If the United States health care system, the medical industrial complex, were a country, it would have been the 6th largest economy in the world in 2010. We spent more on healthcare in the United States than was spent on everything in France. At the same time, our outcomes are not that good. I just picked Canada because we in the United States love to pick on the Canadian healthcare system, and Switzerland because it's the second most expensive healthcare economy in the world. And these are just several little guides of success in a healthcare system. By the way, we in the United States are 49th in life expectancy. The Swiss are 4th, the Canadians are 10th, and we lose out on infant mortality, while white male life expectancy, and per capita healthcare costs. You can see here how different they are. By the way, I said we're 18% of our GDP was spent on healthcare in 2010. If you look at the trend over the last 20 years, and if that trend continues for the next 20 years, we will have healthcare reform in the United States because our economy will collapse around 2030 or so when 30 cents out of every dollar spent in the United States is spent on healthcare. We cannot sustain that. We have overconsumption of resources. We have a system where the greedy feed the gluttonous. The greedy are the doctors, the hospitals, the health insurances, virtually everybody involved in healthcare, the device manufacturers, the pharmaceuticals, trying to sell and make disease, as you so clearly heard in the first talk. The gluttonous are the patients who want to consume. They think consuming more and more is helpful to them, and it just is not. There is indeed a subtle form of corruption going on, and I say a subtle form of corruption because very few people speak up. Very few people are willing to speak up, and everybody's willing to let this continue going on and on. We have modern snake oil salesmen who are offering better than obtainable treatments are actually needed. We have people pushing screening and diagnostic tests that are of no proven value. We have people talking very vaguely about holistic health, about patient-centered health, as they all try to sell things. We have been early adopters of things that seem to be of promise, where good doctors, supposedly smart doctors, say this is a good thing. This is just a list of some of the things that we have done over the years. In the case of postmenopausal hormone therapy, for 50 years, because the Wyeth Company said giving women Premarin, pregnant mare's urine, actually made them feel younger, more youthful, and it was better for them. We did that. People actually criticized Bernadine Healy when she wanted to do the Women's Health Initiative to actually test and see if that was true. So we adopt these things because they seem to be right, and then once they are something that we accept as being true, we criticize and actually attack anyone who actually questions whether or not this is true. Just the number of procedures that we do too often, drugs too early. I think many of you actually know about our history of breast cancer and adjuvant bone marrow transplant in the United States. In the early 1980s, a couple of doctors from Harvard said that adjuvant chemotherapy with high-dose chemotherapy with bone marrow transplant was a good thing for breast cancer patients. And doctors from Harvard are very smart. Mike Berry assures me that's true. And so people started adopting it. Indeed, in 1999, there were 10 states that had passed laws that said that insurance companies had to pay for this procedure because insurance companies frequently didn't want to pay for it because there was no science to support it. There was no study to show that it was beneficial. Women were suing their insurance companies in the United States to get this thing paid for. In 1999, 3 studies were finally published. All 3 studies, back-to-back in the New England Journal, showed that bone marrow transplant was not just a negative, it was net harmful compared to standard therapy. In 1999, within 6 months, 220 bone marrow transplant centers in the United States all quietly closed. 65,000 women had been transplanted in the 1990s alone with this therapy that had never been researched to see if it was actually beneficial. This is the kind of adoption of something that seems to be promising but actually has never been assessed. Too many people, doctors among them, reject the scientific method. Some accept what I call faith-based medicine. Now, they ignore the harms and exaggerate the benefits of a potential new intervention when they decide not to really assess it or not to look at the assessment. When I use the phrase faith-based medicine in the United States, you have to stop and explain very quickly or else some people get mad at you. Faith-based medicine has nothing to do with religion. Faith-based medicine has to do with not respecting and not following the science and accepting one's inclinations and prejudices and allowing it to overrule your ability to actually think we need to scientifically assess this. Now, the scientific method is also under assault. It is a way of putting data and opinion out into the open so we can get its proper perspective. It involves presentation of findings at meetings like this, publications of research, editorials, and letters to the editor. Too often, the news media talks about the new paper and they never go back and talk about the letters to the editor 3 weeks later that show that the new paper is totally false or totally wrong or totally weak. Unfortunately, the news media does not appreciate the scientific method and scientific process. We need to reject faith-based medicine and accept science and reality in many instances. In the United States, where politicians frequently talk about rationing of health care, we need to talk about the rational use of health care. They got the root of the word correct, but they didn't get the word correct exactly. We need to talk about rational use of health care because there's so much irrationality. Now, I'm a cancer doc. I want to explain to you how we got into this problem in cancer because, quite honestly, as our science evolved over the last 160 years, people didn't realize that our science had evolved, and we need our science to evolve a little more. This gentleman is Rudolph Virchow, of Virchow's node. He taught us why blood clots or how blood clots. He was the first person to call himself a cellular pathologist. He defined cancer as a disease involving uncontrolled cell growth. All this while he was in his 30s in Berlin in the 1850s. He was the first person to define leukemia. He defined most of the common cancers using autopsies and a light microscope and drawing the images he saw through a light microscope. He and his students in the 1850s did a series of autopsies. They did thin-cut biopsies. They were the first people to use H&E staining. And with a light microscope, they would draw pictures. This is actually a lung cancer. And had no carcinoma of the lung. And they actually were able to discern all the various things that today we call cancer. By the way, he used the German word, but Virchow called it his profiles of cancer, published in a book. Actually, one of the original copies of the book is at the Mayo Clinic Library under glass, the profiles of cancer. You see, the definition of cancer that we use today in the 21st century is 160 years old. There are people who are getting biopsies in hospitals near here today of 5-millimeter breast lesions. Keep in mind, 160 years. That's after X-ray in 1895, mammography in the 1960s, CT in the 70s, MRI in the 80s, ultrasound sometime along there. We actually have biopsy technology that's been patented within the last 10 years. Somewhere today, a 5-millimeter tumor in a woman's breast is actually going to be biopsied. It's going to be sent to a pathologist who will use the same H&E staining that Virchow used, use a 21st century light microscope. We have electricity now. And he's going to actually say, this biopsy fits the profile that Virchow gave us of what breast cancer is in 1853. Now, the problem, of course, is this 5-millimeter lesion may not be genomically programmed to grow, spread, and kill. Indeed, some people suspect that 20 to 30% of localized breast cancers are not genomically programmed to grow, spread, and kill. Many of us can't expect the public to understand this. Many of us in medicine do not understand the varying biologic behavior of this entity that we call cancer. The fact that some are never going to grow and harm, some are definitely going to grow and harm. I have some hope. Genomic analysis over time may actually help us, but it's important that we not jump the gun and put too much faith in genomics the way we have jumped the gun and put so much faith in early detection over time. Again, healthcare is an issue that must be approached in an ethical fashion, logically, and rationally. So frequently, it is not approached ethically, logically, and rationally. I think all of us need to realize there are things that we know, things that we don't know, and things that we believe. We need to label each one of them accordingly, and we need to understand, especially what it is we believe versus what it is we know. So many people believe early detection and screening and treatment saves lives, but they don't know it, and they don't realize they don't know it. This group really must be vocal in talking about the rational use of health care, talking about these principles. This group needs to be out there on the forefront explaining what really is a complicated message. Public education is important is imperative, especially public education of the health media. Unfortunately, the media that's covering a lot of health stories nowadays, especially in the United States, is not very educated. They don't understand science very often. It's every week I end up talking to some news reporters, and I often end up asking them, what do you do? Because occasionally I have to explain, about every 3 weeks is occasionally, I have to explain that cancer incidence is the number getting the disease, mortality is dying from the disease. You know, mortality is death. Yeah, I have to do that at least once every 3 weeks. It turns out a lot of the people who are covering health stories nowadays were doing street crime the day before, and will be doing street crime the next day. They've just been assigned by their editor to do this new study on breast cancer screening. And then, of course, you have people who I don't know what they're doing. Today we had a CNN anchor announced that there was a new breast cancer screening guideline based on what really is not a very good paper published from the Massachusetts General Hospital. Overdiagnosis. When there are legitimate questions, we need to tell people that there are legitimate questions. So frequently, folks are afraid to talk about prostate cancer screening or breast cancer screening for women in their 40s. We need to tell people when there's a legitimate question. Sometimes informed consent and informed decision-making is actually just telling people, we don't know the answer, or the answer is not known. Occasionally, it's telling people the answer is only known to people who have a financial interest in the answer. Informed decision-making is going to become the norm in a lot of screening tests, especially in cancer. And again, I stress that this group has got to become very active in educating the public, educating the news people, and becoming advocates for education and information. This is really the beginning of the new war on cancer and cancer control in the 21st century. Thank you very much. It's a pleasure to be here.